Thank you for joining the Myositis Association's virtual summit session on managing ILD and myositis. We will begin in a few minutes. There will be silence, but please know you are still connected. Good afternoon. I'm Mary McGowan, Executive Director of the Myositis Association. I hope you've enjoyed the summit so far and have had an opportunity to explore the platform, participate in chats, visit with our exhibitors, and conduct the scavenger hunt. Be sure to tune in this evening for our late-breaking session on how researchers and clinicians are coping with COVID-19. This moderated panel discussion is sure to be a very lively and interesting discussion. Be sure to join us at 6:30 p.m. Eastern Time for this exciting session. Throughout this session, your phones will be muted, but we want to encourage you to ask questions. We will have a question and answer period after Dr. Hallowell's talk. To ask a question, please type your questions into the chat box at the bottom or top of your screen at any time throughout the presentation. It is now my pleasure to introduce this session speaker, Dr. Robert Hallowell. Dr. Hallowell is the director of the pulmonary ambulatory practice at the Beth Israel Deaconess Medical Center and an assistant professor of medicine at Harvard Medical School. He completed both his internal medicine residency training and pulmonary critical care fellowship training at the Johns Hopkins Hospital. His research is focused on establishing the relationship between serum autoantibodies and interstitial lung disease phenotypes. Thank you, Dr. Hallowell, for joining us today to share your expertise on managing ILD and myositis.
Hello, my name is Robert Hallowell. I'm a pulmonary physician at the Beth Israel Deaconess Medical Center in Boston. And today we're going to talk about managing myositis-related interstitial lung disease. I have no financial disclosures. The objectives are to understand why interstitial lung disease is a significant complication of myositis. We'll then farm in New Hampshire. She was not a smoker, and she had had a surgical lung biopsy. And the pathologist commented on a possible inflammatory interstitial lung disease and a possible diagnosis of hypersensitivity pneumonitis. Now, this is a diagnosis that one makes when you think that there's a possible autoimmune phenomenon or an allergic reaction in the lung, usually to an organic antigen or an exposure. And in this case, it was thought that maybe her exposure to chickens on the farm was causing an autoimmune reaction in her lungs and her interstitial lung disease. And I show her CAT scan here, and I don't expect you to be a radiologist, but you'll have to trust me when I say that for the most part, the lungs are supposed to be primarily black in color on a CAT scan. And so most of the white and haziness that you see in the lungs, aside from the heart and the large blood vessels in the center, is abnormal inflammation. She had a lot of blood work performed, what she called probably 100 tubes of blood, and there was no evidence of a rheumatologic disease. When I met her, she was being treated with immunosuppression. She was on prednisone at a dose of 40 milligrams daily and Cellcept, or mycophenolate, at a full dose, which is 3,000 milligrams a day. In order to round out her rheumatologic workup, despite the 100 tubes of blood, I ordered some additional testing. And it turns out that she had a specific antibody in her blood, part of what we call the myositis panel. Her specific antibody was one called anti-PL12, and this is an antibody that we specifically see in patients who have myositis. Because of this finding and this specific blood work, I changed some of her treatment and added intravenous immunoglobulin. This is a representative slice of her CT scan, and you can see that some of that whiteness, some of that inflammation on the CAT scan actually improved significantly. But more importantly than the CAT scan looking better, she felt significantly better. She felt as if she got her life back. Now, interstitial lung disease is very common in patients with myositis. The reported prevalence ranges anywhere from 20 to almost 80%. And the range is very broad depending on how you define interstitial lung disease, whether you're using breathing tests, high-resolution CAT scans. And if you add an anti-synthetase antibody, which is the kind of antibody she had, the prevalence is even higher, anywhere from 70 to 100% in some series in the literature. The interstitial lung disease can precede the diagnosis of a muscle disease or a myositis in up to a third of cases. And this is what happened in her. So she had interstitial lung disease first. We did a blood test that showed evidence of a possible underlying myositis. Many months later, when we were trying to actually wean down her mycophenolate and some of her prednisone, it was only then that she actually started to develop certain signs of a rash and some muscle weakness, more classic of dermatomyositis. So she was one of these cases where her interstitial lung disease preceded the other myositis signs. Now, interstitial lung disease can come in many different flavors and patterns in people with myositis. And this is just a graphic demonstrating that interstitial lung disease can take different forms, and the radiologist or your pulmonologist may use a different alphabet soup to describe that. And the terminology we use is really based on either the pathology or radiographic findings when we do the CAT scan. And sometimes that can have implications for the type of medication we might use or what we expect the disease to do in terms of how fast it may progress or how stubborn it may be when we try to use different medications to treat it. In general, how responsive is interstitial lung disease to treatment if there's an associated myositis? How do patients do? This is just one representative study, but it was a large study of about 107 patients. It was retrospective, meaning they looked back in time going through the charts. About half of them got steroids alone, and about the other half had some other form of immunosuppression in addition to the steroids, either azathioprine, cyclophosphamide, or mycophenolate. And you can see on the right, about a third of them had complete resolution of their interstitial lung disease, and half had improvement. So that's pretty good odds that you're going to feel quite a bit better with treatment. Now, there was a fraction that had deterioration despite treatment, and those patients had progressive disease and probably required additional therapy beyond what is listed here. And so some people do have a more refractory course. This slide illustrates some of the telltale features on the skin that we can see in patients who have dermatomyositis. Some of you may have experienced these findings. You can have punched out ulcers. You can have a rash around your eyes, what we call a heliotrope rash. You can have rough thickening of the skin and some redness on the tops of your hands, what we call Gottrin's papules. You can have thickening or cracking of the skin on your hands and fingers, what we call mechanic's hands. Or you can have a shawl sign, sort of a rash over the upper shoulders, chest, and back. And these can be tip-offs to either your primary care doctor or rheumatologist that you could have an underlying myositis. And certainly when these findings are present in somebody with interstitial lung disease, it prompts us to do additional blood work to rule out an underlying rheumatologic pattern. But as we saw in the case vignette, these signs are not always apparent right away. And so most of our patients with interstitial lung disease get a whole battery of blood tests. And that's illustrated in this study. The reason we get what seems to be 100 tubes of blood on some of our visits is because if we don't do such extensive blood work, sometimes we can miss things, and that can be important. So one study looking at 165 patients who came into a clinic with what was presumed to be an unknown cause of interstitial lung disease, what we would say is idiopathic. It's just a fancy word for we don't know what's causing it, and it just sounds better to use a word like idiopathic than to say we don't know why. Of those patients, about a quarter of them actually were found to have an underlying autoantibody consistent with a possible myositis. And the diagnosis actually changed because of that blood work 8.5% of the time. And what's interesting is that in the study, many of these patients were thought to have a condition called idiopathic pulmonary fibrosis, or a progressive known fibrotic lung disease, typically not associated with any known autoimmune or rheumatologic condition. And so the blood work does matter. This slide illustrates some of these fancy antibodies that we test for, one of which was used in the original case vignette I presented to you. And these are some of the myositis-associated antibodies. And the initials you see here are usually the initials of the very first patient in which they were discovered. Some of them are associated with certain phenotypes or certain clinical features, and they can point us in the right direction and guide our treatment on certain occasions. I'll use this case to point out that the lungs can sometimes have a mind of their own. And many of you will have not only a rheumatologist, but a pulmonologist. And sometimes the medications we use to treat the joints or the skin disease are similar to the medications we're using to treat your underlying interstitial lung disease. But the lungs don't always behave and follow the same course as the other parts of the body. For instance, in this case, this was a 60-year-old woman who had underlying myositis and one of these known antibodies, anti-PL7. She had joint pains, fevers, and a rash that was sort of the primary initial complaint that brought her to the rheumatology clinic. But after she had been on prednisone and a high dose of mycophenolate, all of these symptoms improved. And so in the rheumatology clinic, people were quite pleased and thought that she was actually doing quite well clinically. That being said, her cough and shortness of breath when trying to carry laundry up the stairs was actually getting worse. This is her initial CAT scan, and you can see that over time, there's progression and increase in that gray, sort of white inflammation in the lungs. And so even though her joints and her skin and other rheumatologic aspects of her disease were getting better on therapy, her lungs were actually getting worse at the same time. And so it's very important that rheumatologists and pulmonologists work closely together because the lungs don't always follow the other parts of the body. Now, conversely, this is a case of a 68-year-old man who came with progressive shortness of breath over several months. we did breathing tests and found that his vital capacity had actually decreased by 15%. And so there was a concern naturally that his lung disease, his interstitial lung disease, might be worsening. But when I got a repeat CT scan, it was almost identical. I then did some additional breathing tests and found that his respiratory muscle strain, so were actually quite weak. Further evaluation, yet again more blood work, demonstrated that his muscle enzymes had actually risen quite dramatically. So his muscles were really inflamed. And so here, the lungs were behaving. His lung disease had not progressed, and therapy was actually quite effective at keeping his interstitial lung disease in check. But this time, his myositis was flaring up, and he was getting more muscle weakness. And that muscle weakness was affecting the muscles needed to breathe. And so he was interpreting that as shortness of breath, and his breathing tests were showing that as well. And so the lesson here is that not all shortness of breath in patients with myositis is necessarily because of a problem with the lungs. And that sometimes the muscle weakness can develop after the interstitial lung disease. And this can happen anywhere from 29 to 64% of the time. Flip that around and keep in mind that sometimes when the breathing tests look like they're getting better, this may give us false reassurance in the pulmonary clinic, because this could just be a consequence of the respiratory muscles getting stronger and may not actually indicate that the interstitial lung disease is improving. And so I think the general take-home message here is that we always have to interpret our breathing tests with a grain of salt. And if there's a true question about what's really going on with the lungs and what's really going on with a patient's breathing symptoms, sometimes we just have to get a CAT scan in order to get a true look at the lungs and make sure that there isn't more inflammation going on there. What about cancer? This comes up quite a bit. Patients ask me if they're at increased risk of having cancer if they have dermatomyositis, or if they have a positive autoantibody or an antisynthetase antibody. And I use this picture here to demonstrate that sometimes we have cases where the interstitial lung disease or the myositis seems to be incredibly stubborn, and we don't know why. We can't figure out why our treatments aren't working, why the patients are not responding clinically when we think they should. And in those cases, we have to have a high index of suspicion that there could be a small underlying cancer driving the autoimmune process. Malignancy does tend to be more common in patients who have an underlying myositis. This is illustrated in this one study looking at 165 patients where the rate of cancer was about 12%. 12% is higher than the baseline population. And of the 19 cases in this study, 3 of those occurred after the diagnosis of interstitial lung disease. And so what I tell my patients is that at a minimum, we have to be very vigilant with routine cancer screening. So everybody of a certain age, if you're over the age of 50, has to have their colonoscopy. Women, if it's appropriate screening, have to have their pap smears, their mammograms. And if there's any index of suspicion, pretty much at baseline, all of my patients are getting a CAT scan, not only of their chest, but of their abdomen and pelvis to rule out any underlying small masses that may have been missed. I also have a pretty low threshold to get a PET scan, which is a specialized CAT scan that looks for signs of cancer. I don't do that in all patients, but I have a pretty low threshold to do it if I'm suspicious that there might be an underlying cancer somewhere. But what about treatment? I think it's important to note here that many of the therapies that we use are what we call off-label, meaning they're not approved by the FDA in order to treat interstitial lung disease or myositis. That doesn't mean that they're not standard of care or effective. It just means that we don't have large enough randomized clinical trials in order for the FDA to give an official approval for them to be used in that context. Sometimes that creates a problem with insurance coverage. The idea of treatment with this condition is that we think the immune system is out of balance. Now, typically the immune system is a good thing. It's necessary to keep us healthy, to fight infections. But in patients who have an autoimmune process, whether it's myositis or an autoimmune interstitial lung disease, the immune system is too strong and starts attacking different parts of our own body. And so the balance is shifted. And so we need to use therapies that turn down the volume on the immune system to put balance back. Traditionally, these initial treatments involve corticosteroids and other medications that we call steroid-sparing agents. These steroid-sparing agents are medications that also act to reduce the immune system's activity, although they tend to have less negative side effects than steroids. Some examples are mycophenolate or Celcept, azathioprine, also called Imuran, or certain calcineurin inhibitors such as tacrolimus. The most commonly used agents used to treat interstitial lung disease in patients with myositis are corticosteroids. They're inexpensive, they work very rapidly, they're easy to titrate and taper off, and most physicians are extremely familiar with them. They also don't require any routine blood work. That being said, they're fraught with many really bad side effects, and a lot of patients don't like the way they feel when they take them. They can cause mood swings, insomnia, weight gain. They cause an increase in blood sugars, whether patients have diabetes or not. They're associated with bone loss over time. They can cause cataracts, easy bruising of the skin, and sometimes even permanent adrenal insufficiency. Because of that, we often use other medications called steroid-sparing agents in order to minimize the amount of corticosteroids our patients have to be on. These include medications such as azathioprine, mycophenolate, and tacrolimus. Now, it's important to keep in mind that we don't have really strong evidence that any one of these agents is better than another, and so they can be used interchangeably. The advantage of these agents is that they can be a lot more powerful than corticosteroids and can be used when steroids aren't strong enough to control interstitial lung disease and myositis. They don't have any of the side effects that corticosteroids have. So none of the mood swings and weight gain and bone loss and all the problems I mentioned on the previous slide, you don't typically see that with these agents. And so they can help you get off prednisone and spare you those side effects. Some of the disadvantages is that they can be extremely expensive if we can't get insurance coverage. And as I had mentioned a little earlier, because they're not necessarily FDA approved for the treatment of interstitial lung disease, they're not always covered. They have a slower onset of action, and so unlike prednisone or other steroids that can work very quickly, they can take several weeks to months to sort of have their full effect on the lungs. They also require routine blood tests in order to make sure that patients aren't having low blood counts or liver abnormalities. And there's also a concern that over time, they can slightly increase the risk of certain skin cancers or lymphomas because of the way they work on the body's immune system. Another steroid-sparing agent that requires special mention just because it's slightly different from some of the others is a medication called rituximab. Unlike the other steroid-sparing agents which are taken as a pill, rituximab is an infusion that's given twice every 6 months. So it's a lot more convenient, and it's thought to potentially be good for refractory cases that maybe haven't responded to some of the other steroid-sparing agents. Routine blood draws are not required, as they are with some of the other steroid-sparing drugs. But the downside is that once you have the myositis is intravenous immunoglobulin. These are monthly infusions given over 3 days, and it's a blood product that can cause headaches and a slight risk of blood clots, and so it's a little bit cumbersome in that sense. But the advantages of intravenous immunoglobulin is that it can help in refractory cases and doesn't carry the same risk of infection or immunosuppression as some of the other steroid-sparing agents. is there a role for antifibrotic therapy? And so antifibrotics are a group of medications to slow the progression of scar tissue formation and to slow the decline in forced vital capacity on breathing tests. And I've shown you the data here. And so you can see that the line on the top are patients treated with nintedanib, and the line on the bottom, you can see a steeper decline in forced vital capacity, are the patients treated with placebo. Now, these are patients who have a progressing fibrosing interstitial lung disease. So they have a decent amount of scar tissue seen on their CAT scan. The diagnosis they have is variable. Different causes ranging from hypersensitivity pneumonitis to rheumatoid arthritis and other interstitial lung diseases, about a quarter of which were characterized as being an autoimmune type of interstitial lung disease. That being said, these patients did not necessarily have myositis, and so we would have to extrapolate the results of this trial to patients with myositis and assume that myositis patients would reap the same benefits. Now, treatment is not just about medications. Patients with interstitial lung disease and muscle weakness of any kind can get great benefit out of pulmonary rehab. Now, pulmonary rehab is a structured exercise program in a monitored facility where medical professionals can keep an eye on your heart rate, your oxygen levels, your respiratory rate while you're exercising, and they can coach you and encourage you to push yourself a little bit harder than you otherwise would on your own. They can also give you tips on how to conserve your energy. They can guide you on breathing techniques. They can give you exercise guidelines, nutritional support. They can help you with oxygen utilization if you're a patient who uses oxygen. They can also help you use your medications if you're a patient who has certain inhalers, and they can show you how to use your inhalers properly. I've never had a patient who has gone through pulmonary rehab tell me that it wasn't worth their while or that they haven't gotten something out of it. So I think this is something that you should strongly consider if you haven't done it already. What about routine monitoring in order to stay healthy? So in general, our patients with interstitial lung disease are getting pulmonary function testing every 3 to 6 months, and that range will depend on where you are in the course of your disease, whether you're newly diagnosed, and how active your disease might be. And so if your disease is stable and you're doing perfectly fine, you may only need pulmonary function test every 6 months, maybe even 9 months. Repeat CAT scans are typically done at the discretion of your doctor. If there is a sudden change in your breathing test or a change in the way you're feeling that may prompt a CAT scan, you may need routine safety work depending on what kind of medication you're taking. And don't forget to get your routine vaccines. Sometimes you may need prophylactic antibiotics depending on what medications you're taking. You may inquire about a bronchoscopy, or it may be recommended that you have a bronchoscopy. And this is a procedure where we put a camera through your mouth into your lungs in order to get a sample or a washing from inside your lungs. This procedure is typically done to rule out an infection. It's not usually very helpful to diagnose the type of interstitial lung disease because the biopsies that we can take through that narrow bronchoscope are usually not very telling or helpful to a pathologist. Surgical lung biopsy is typically avoided in patients with myositis. We don't usually need to have a piece of surgical tissue if we know that there's an underlying myositis driving the interstitial lung disease. And in patients with myositis, the act of going through surgery can actually lead to a flare-up of your lung disease. And so we almost always recommend against a surgical lung biopsy. And I'll take a moment here just to say that this is a complex disease, and patients with myositis and interstitial lung disease are complex patients. And so we need a multidisciplinary approach here. And this involves pulmonary, rheumatology, pathology, radiology. And while sometimes too many cooks can spoil the broth, When everybody works together and we have a symbiotic relationship, sort of the way the clownfish work on the barrier reef, patients get better care, and it's a lot more gratifying for everybody involved. And I'll end here just with a little bit of hope. And I think the more we understand a disease process, the more we're empowered to treat it. And so this is just some ongoing clinical trials looking at patients with myositis and interstitial lung disease and different treatment modalities to give us a better understanding of how we can treat this disease going forward, which medications might be more effective, and some new treatment modalities that we could use in the future. So in summary, interstitial lung disease frequently coexists with myositis, and having interstitial lung disease can pose unique challenges for you as the patient with this condition and for your doctors. Treatment may involve steroids and other immunosuppressants, and additional research is needed to better define optimal treatment strategies. Thank you for your time.
Thank you so much, Dr. Hallowell. That was such an informative session on interstitial lung disease. And Zarun, if you can please make it possible, Dr. Hallowell would like to be on video. And as a reminder for everyone, if you would like to put questions into the chat box, you can use the chat box below or above to type your questions in, and we will have the opportunity to have a Q&A session. And remember to type your questions into the chat box below or above in order to have questions. And we got a number of questions throughout the session for you. So if is it possible for someone to have ILD and IBM? Is there a connection and an overlap possibly with PM?
Yeah, so it's certainly possible to have overlaps with several of these conditions. Certainly, if by PM you mean polymyositis.
Yes, polymyositis. Mm-hmm.
Yes. Interstitial lung disease coincides with polymyositis, dermatomyositis, and inclusion body myositis. Now, inclusion body myositis in general tends not to be associated with interstitial lung disease. So inclusion body myositis is the one inflammatory myopathy that doesn't seem to be associated with lung disease. But dermatomyositis, polymyositis, most certainly. And then, antisynthetase antibodies themselves are associated with a muscle inflammation. And, in recent years, the past 3 to 5 years more specifically, there's been a lot more research looking at the specific type of muscle disease associated with some of these specific antibodies that I mentioned in the talk. We used to think that maybe the myositis was similar in all these patients. And what we're starting to learn is that not only is the lung disease maybe a little bit different depending on the type of antibody you have, but that the actual muscle disease might be a little bit different under the microscope. Whether that has different implications for treatment when you're talking about treating the muscle aspect is yet to be figured out. Needless to say, I focus sort of on the lung part of it. And so, when it comes to sort of the nitty gritty of the muscle stuff, I leave that to the rheumatologists who tend to be smarter than I am. But yes, any, whether it's polymyositis or dermatomyositis, we frequently see that association with interstitial lung disease, regardless of which one.
Great, thank you. And so we also got a number of questions with regard to the treatment course. And so there was a number of different people that wanted to know, how you kind of think about the lines of treatment. And so there was a number of people thinking about, I've been on steroids, I'm taking, Cellcept and Rituxan. And so, how do you think of the line of treatment and what's your third line treatment? What's your first line treatment? What's your kind of treatment course that you kind of run through for folks?
Yeah. Well, I'm going to start with a disclaimer, like any good physician would. And I think it's important to recognize that there's probably no right way to do this. Or maybe I should say the right way to do this is the best way for each individual patient. And so I think you need to have a calculated, thoughtful approach, and the approach has to involve an in-depth conversation between you and your doctor to figure out which treatment is going to be most appropriate for you. And so what that looks like. So, oftentimes we will start with steroids if a patient is really sick or having a lot of symptoms because we need something that's going to work quickly. I alluded in one of my slides that steroids have a lot of side effects and patients don't feel good on them. And so I tend to view steroids as a short, temporary matter or measure, and that the goal should always be to get patients on the lowest dose of steroids possible in the shortest amount of time. Because I do think they're associated with a lot of toxicity and long-term side effects, not the least of which is terrible bone health. And so then the question is, if we want to choose, a steroid-sparing agent, how do we do that? And I think a lot of this comes down to physician comfort level and familiarity with these different agents. And I can say that because the data is pretty scarce. We don't have large clinical trials, randomized clinical trials, the way they do in cardiology, where they'll have 50,000 patients randomized to a certain statin for heart disease. And we just don't have that luxury with this condition because it is relatively rare. And so there is not one agent that is proven to be safer or more effective than another. In general, I tend to use mycophenolate or Cellcept as a first-line agent. It's effective, it's safe, it seems to be the best tolerated as a first-line agent. That being said, azathioprine is also equally as effective. And that would be the first agent I typically go to. And then other things such as rituximab typically get added on if agents like mycophenolate are not effective. That being said, there are many situations where that gets flipped around sometimes. Certain patients who have underlying disease features that are more in line with a rheumatoid arthritis phenotype, let's say, where they're having a lot of joint conditions, sometimes the rheumatologist may want them on rituximab up front before mycophenolate, let's say. Or sometimes they have a lot of gastrointestinal issues or a history of colitis where mycophenolate wouldn't be a good option. So there are a lot of different factors that come into play that may push us to use one agent over another. And so we have to look at the whole picture and the whole patient to decide sort of what the tailored approach would be. And so we kind of do things in a stepwise fashion. And then, certainly if patients have side effects to one type of medication, we would obviously look to switch to another. And different medications always have certain, different side effects and risk factors. We talk about things like pregnancy, if there are certain, other, things to consider along those lines, depending on the age of the patient as well. And so I think it's always important along the way that there are open lines of communication. I think it's very important that patients and physicians are talking about what their goals are, how they're feeling on certain medicines. I think the goal is always to improve the quality of life. And so if medications are making you feel poorly, then something is failing. And so, the treatment shouldn't be worse than the disease. And so there's usually other options. And so I think it's important to not be suffering through the treatment as well, and to make sure you call to attention, something that you're having trouble with when it comes to one of the therapies you're on. And so that tends to be my general approach.
Thank you. That's really helpful. You talked a little bit about people getting worse or measuring them, their disease getting worse. And there were some questions about that. How do you determine whether somebody is getting worse or getting better? Is it based on certain kinds of tests? What's your evaluative feature for that?
Yeah. So the first piece starts with, you as the patients telling us, as your doctors, that something doesn't feel right. And, I think the most important thing is that we trust you to know your body. And so if something feels different, we need to pay attention to that. And, all of these autoimmune conditions can be very funny in the sense that they can affect all different parts of your body. If they're affecting your muscles, I know from doing work around the yard that there are muscles I never even knew I had until I hurt them, right? So if something in your body feels off or feels different, we need to pay attention to that. That doesn't mean that we need to be alarmists and hypochondriacs, but it means that if something is different than it was before, it is our job to listen to you and then to investigate that. And it's the same with your breathing and your lungs. You start to get to know your lungs very well. And so when you notice a change, that should prompt us to investigate. And so the first level of investigation typically involves pulmonary function testing. Now, pulmonary function testing is not a perfect science. And, there's a lot of subjectivity to it. And that subjectivity is the technician, how well the technician coaches you in terms of taking that deep breath in and blowing out as hard and as fast as you can, right? So, the effort you put into the test can affect those numbers. But assuming you're doing the test the same way every time, those numbers can actually be a very good metric for the way your lungs are. And so if we see any kind of change in some of those numbers on your breathing tests, either what we call the vital capacity, which is the size of your biggest breath, or what we call the diffusion capacity, which is how well your lungs are able to take oxygen from the air and absorb that oxygen into the bloodstream. A change in one of those two numbers is a tip-off that possibly you have more inflammation or more scar tissue in your lungs. And so if I see that change on the breathing tests, that would raise a little red flag and prompt me to then potentially get a CAT scan to look for more inflammation on that CAT scan, more scar tissue on that CAT scan. And from there, we could then potentially adjust your medications, either increasing your immunosuppression in the form of the prednisone or changing your dose of mycophenolate or the frequency of your rituximab or whatever medication you're on. And so that's sort of how that you start from the line of communication all the way through the workup to a medication change if necessary.
Thank you. That's really helpful. And building off of what you just said about the pulmonary function test, we did get a question that's kind of related to the times we're in right now. So the question, it has to do with whether or not the pulmonary function tests are safe in the time of COVID and whether it is something that, we can pursue in this current climate, and love for you to weigh in on that.
Yeah. So, this has been obviously a challenging time for everybody. And, certainly on the hospital side, for the medical staff, but for the patients, for all of you out there, this has been a horrendous time. And first of all, thank you for doing your part, for, the social distancing you've been doing, the sacrifices you have been making, which has been making our jobs easier. And, I don't think you all get the credit you deserve for what you've been going through. And I can only imagine, the anxiety you have as patients, knowing you have underlying health conditions to make it all the harder. It's an added level of anxiety and angst that you're dealing with. And so this comes up a lot. And, our clinic has been shut down for a while. We've been having mostly phone visits, video visits, sort of as a stopgap. And I've been speaking to most of my patients, and God bless them. They're all sending me messages asking if I'm okay. And, which is just so inspiring. And yet I should be asking them if they're okay. So, there's just a lot of love and inspiration going around, which shows how bad times bring out the best in people, I believe. But to answer the question about breathing tests, these clinics have been closed down, and, phone visits are great to get sort of the subjective piece of how people are doing. And for the most part, if people say, I've been able to walk and I have an oximeter on my finger that looks the same and my breathing feels the same, up until now, we've been able to say, okay, things are probably unchanged. We can skip your breathing test for now, because in general, the risk of coming in and, taking the chance of getting sick, that risk probably outweighs the benefit of getting a few numbers. So we can push that off a few months. I would say that now we are reaching a point, I can only speak for my own institution here in Boston, which has been hit extremely hard. So if I can say this here, it probably holds around the rest of the nation. we are starting to open things up, and I direct the clinic here, so we're part of this sort of rolling out plan, and we're starting to bring in patients that are of the highest need. And a lot of that involves our interstitial lung disease patients, because you start reaching a point where we have to be able to monitor your lung function. The clinics are now being cleaned, and we're keeping the COVID patients out and screening so aggressively and spacing patients in such a way that I think in the next few weeks, it's going to be reasonable and safe to start doing that. Certainly, I think within another month, I would say the risk of coming in to a clean clinic where all precautions are being taken, that risk is probably going to be equivalent to going to the grocery store or going to your local pharmacy to pick up a medication. Because the clinics are being completely separated out from an inpatient hospital ward where there are known sick patients. So I think the risk is becoming minimal, because I think we start reaching a point where we can't go 9, 12 months without having pulmonary function testing to start, to pick up changes in lung function. That would be important. Likewise, patients who are on medications, if you're on mycophenolate, if you're on azathioprine, if you're on tacrolimus, you need to have safety blood work done every few months. And so, we have patients who have also been putting off some of that blood work because they're afraid to come into the clinic to get the blood work done or go to their local Quest to get the blood work done, et cetera. But you can only go so long without having that blood work checked, because it can become quite dangerous to not do so. But again, those facilities, I think, have now learned and are now actually quite sterile, quite clean. And I think we're reaching a point where it's going to be okay to start doing that stuff, in the next few weeks, assuming, that the coronavirus numbers and the curve continues to move in the direction that it's moving.
Thank you. That was so helpful. So I did want to address, and we got quite a few questions around this as well. The question about if somebody is showing likelihood of sort of asymptomatic ILD, or it seems like their ILD is sort of stabilized, or it's maybe something like a remission, they just sort of seem to be at this sort of stable position. Can it show up and get worse later on down the line?
Yeah, so that's a great question. So this is sort of the idea of having a latent ILD or a stable ILD or an ILD in remission. And so we have many patients who have interstitial lung disease that, is active and it's flaring and it's very aggressive initially, and either because of the treatment we give them or just because over time their immune system quiets down and gets tired of torturing them, for lack of a better term, things settle down and they catch a break, and things go quiet. And it can stay that way for decades and never be a problem again, and they can have stable lung function, and that's great. There are instances where previously stable interstitial lung disease can flare up again. And we do see instances of this. And so the things that can make previously quiet interstitial lung disease flare up again, infections can do that. So if you get a pneumonia, whether it's bacterial or viral, that can sort of awaken the immune system again and cause that underlying ILD to flare up, whether it was mild or severe to begin with. And then anything else that stresses the body in a medical sense, typically surgeries. So we have had some cases where patients have a very mild form of interstitial lung disease that sometimes they didn't even know about. They go in to have a surgery, whether it's a hip replacement or a shoulder surgery or a knee replacement. And the act of being on a ventilator or a breathing machine or having the surgery done sort of stirs up inflammation in the body, and that can trigger a flare-up of the previous interstitial lung disease. That's not very common, so it's certainly less than 10% of the time that something like that happens, but it is a possibility. There's nothing, to the best of our knowledge, that can prevent that. So, we wouldn't put people on strong medicines or suppress their immune system ahead of time to prevent that. It's just a risk that we're aware of, and if it happens, we tend to treat it very aggressively up front and try to suppress that, that inflammation and control the situation.
Well, thank you so much. This was such an informative session, and thank you for answering all those questions. And we really appreciate you taking the time to speak with us and share your expertise on this. And as a reminder, this session has been recorded, and as a registrant of this session, as a registrant of this conference, you can come back and view this session again anytime you want to after today's live event for the next 30 days. All the videos will be available in the auditorium and in the video vault section of the platform. And now please go ahead and explore the exhibit hall and engage in the chat rooms before our next session, the role of exercise management of myositis with Dr. Eric Ensrud, which will begin at 3 p.m. Eastern Standard Time. And thank you again. Bye-bye.